Um, Dr. Cortez, are you ready? I will introduce you, okay? I have a pleasure today of introducing our speaker, Dr. Roberto Cortez, Surgery and Surgical Critical and Trauma Fellow at Ryder Trauma Center, Jackson Health System, Miami. Thank you, Dr. Cortez, for accepting our invitation. Are you ready to start?
Yes, ready. Just wanted to make sure everybody can hear me okay. Okay, I'll get started. It's an absolute honor and pleasure to have the chance to speak with everyone. So again, my name is Roberto Cortez. I go by Bobby Cortez here at Ryder, which is what everybody calls me. My training background, I did my MD at UT Southwestern in Dallas, Texas. I completed my general surgical training at Brown University in Providence, Rhode Island. And then I was thrilled to have the chance to come down to Ryder Trauma Center with the team here in Miami to round out my fellowship in critical care and trauma surgery. And one of many, I would say, reasons that I was very excited to have the opportunity to be here at Ryder were for days like this, where you have the chance to exchange complex cases and management strategies with colleagues all over the world, which I thought was a phenomenal chance to hear different perspectives and insights from all of our colleagues. So again, it's kind of surreal how excited I was at the chance to be exposed to that type of environment, and now having the chance to go over a case with all of you. So again, thank you very much for your time and attention. Good morning, good afternoon, good evening, all over the world, wherever you are. So we'll get started. So I titled the talk, The Motorcycle Diaries, Miami Edition. And you can see here from the picture, it's very Miami, but I felt like this was fitting for the trauma that we saw at a night when we were on call at Jackson South. So I'll start by saying I have no disclosures, and we'll just run right into the case. So the trauma alert came through on a page. It was a weekday. It was around 8 p.m. And the page went out as follows: 18-year-old MCC or motorcycle collision, no further information given. So my attending, Dr. Lieberman, and I were the two trauma team members on call. And this was the point where, you know, we had a relatively straightforward day with not many activations at all. And this was the first page that went through actually for all the trauma activations for the day. And so this idea of kind of elevator thoughts or hallway thoughts as you're walking down the hall, not really knowing what to expect. And Dr. Lieberman and I gave each other kind of a look thinking, you know, this could be nothing or it could be really, really bad. So let's just see what we find. And we're walking down this long hallway to the resets bay. And sure enough, it was the case we're presenting today. So obviously this ended up tying up the majority of our night. So I'll start with the primary survey. The patient showed up from EMS, was tachypnic on a non-rebreather. He was estimated to be about a 17 or 18-year-old male that sustained a helmeted motorcycle collision. As he rolled through the door, EMS was giving us this information. So going over his primary survey, the patient was tachypnic on a non-rebreather. He had a needle decompression placed in his left chest in the field. So he arrived with a needle in his left chest. Vitals preliminarily were tachycardia to 120 and hypotension with a blood pressure of 85/60 with no obvious areas of active external hemorrhage. He was moving all four extremities. He was able to state his name and briefly what happened, giving him about a GCS of 14 on arrival. And we noted just on gross exam of everything, he had deformities to his bilateral upper extremities, his left lower extremities, and he had pulses and actually signals down in the left lower extremity that I'll get into. So again, as I learned to navigate this kind of format of the conference, I have different steps throughout the presentation where I can stop and discuss. So feel free to jump in at any point or during these times, or I can continue. So just let me know.
Thank you, Dr. Cortez. Dr. Cassin, could you please share your experience?
So I'm curious to see why they placed left chest needle, and if they did place one, I would like to know exactly where they placed it, and I would like to know what type of needle they use. And was there any external bleeding at any of these parts? because that will take priority. You need to stop the bleed. And he's obviously hypotensive, and you would try to correct that by blood if it is available, and very little fluid. Don't drown him with fluid, and 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 try to see if he's a responder or a non-responder. And then after that, you'll have to make a decision what the next step is going to be. Thank you.
Thank you, Dr. Kassim. Dr. Antrak, do you have any comment? Sorry. Dr. Supa, can you hear me? Dr. Collet, can you hear me?
Yes. I think these patients need to find where is the patient's in shock. So no external hemorrhage, but the patients maybe have bleeding for other swells. So at this moment, I think the most important thing is to get assessed, thinking about massive blood transfusion, and trying to finding where is the bleeding surrounds. So try to compensate the patient, make an X-ray and of chest, my X-ray of the the pelvis, and try to, if possible, make a ultrasound, abdominal ultrasound fast, for to try to find where is the blending. And the extremity skull pulses is diminished because the shock, or the patients may be some arterial injuries or aorta injury or aorta dissection. So it's very important to try to finding where is the blending surrounds. That's it.
Thank you, Dr. Collet. Dr. Namias, do you have any comment?
Yeah, chest X-ray, fast exam, and rock the pelvis for stability, and go from there.
Thank you, Dr. Namias. Dr. Supa, can you hear me? Dr. Antrak?
Yes, so yeah, I basically agree with the other comments. 2 large bore IVs, and I would and then set up for the massive transfusion protocol, no more than 1 liter of crystalloid, and then move to blood. And the EFAST to look at both chests and also the abdomen to see where the bleeding is. And I think the chest X-ray and a pelvic X-ray, they're fine, but he's in shock, so need to find the source of the bleeding, and then proceed either to thoracotomy if it doesn't slow down, or chest tubes, or laparotomy. And then I would splint the extremities, reduce them and splint the both arms and the left lower extremity.
Thank you, Dr. Antrak. Dr. Cortez, your turn, please.
Yes, thank you all. Wonderful comments and insight. I appreciate it. So just to round out the primary survey along with the interventions that we achieved. So the patient, obviously, as you said, grossly in shock, gross deformities, profound blunt trauma. With the needle decompression, to speak to one of the questions, it was in the left second intercostal space, large, probably about a 14 gauge angiocatheter. For reportedly diminished lung sounds in the field. So this kind of happened in concert in terms of all these interventions. There was a left chest tube that we quickly placed within the left chest, with another one of the attendings working with us, able to place the left subclavian cordis, at which point we started massive transfusing the patient with a hotline that was in the room. The patient was intubated to further expedite our workup and to kind of take control of the situation. So just as a top-down kind of global approach or global overview of our primary survey and the interventions, the patient was now intubated, a left chest tube was placed, a left subclavian cordis was placed, and blood was immediately transfused. The patient was at this point sedated, and we did perform the following primary adjuncts, which I'll go over here, which we can see. So the chest X-ray, we can see our left chest tube in position, the ET tube in position, and then our pelvic X-ray here showed an open book pelvic fracture, bilateral superior inferior pubic rami fracture, and a fracture of the left sacroiliac joint, which was followed by a binder placement immediately with the resultant chest X-ray after here. I apologize, I don't have the fast imaging, but the fast was noted to be positive. There was fluid in the in Morrison's pouch on our EFAST.
Bobby, but the absence, that the absence of his symphysis pubis would have been apparent on physical exam. So that binder could have actually been on earlier, right?
Yes, sir.
That would be
Absolutely.
immediately evident on exam.
Yes, yes.
Yeah, can I say something?
Of
Hello?
course.
Yeah, I'm sorry I arrived late because there's no link in my computer to go into you guys. A couple comments. You guys believe in this needle decompression in the field? And almost 25 years I was in shock trauma. I would come to the conclusion that more damage than good. Maybe in Miami they are very good at paramedics, better than Baltimore, but we saw many damage with this needle decompression in the field. And sometimes the colon is in the chest and we see caca coming from the needle. So I never seen it anymore. So I thought that was still a extremist measure when the patient is dying and obviously have a tension pneumothorax. Second, the rumbling, they do the lambada and the pelvis. I don't know. I used to do that, but then I read and maybe makes sense that you have to be careful with that to start seeing stability. And I agree with Dr. Namayas that I would put earlier, there's a role, Cortez, I think you are Latino. I don't know, you come from Colombia, Venezuela, someplace like that. They still use the physical examination. The patient has a bluish thing there that looks suspicious. The sheet is early to place. Similar here was placed much later. Thank you.
Thank you, Dr. Rodriguez. Dr. Cortez?
Yes, yeah, thank you for comments. Absolutely. This is without a doubt a lesson in remaining systematic in your physical exam. And you're right, the appropriate pelvic x-ray that we should have gotten for this patient should have already had the binder in place. So it's absolutely a learning point for me going forward. To go on to the remainder of the secondary survey, just as a top-down intubated, no obvious craniofacial trauma, left chest tube was in place. The abdomen had no overlying bruising, the pelvic binder was in place, there was no blood on rectal exam, the patient had a Foley catheter at this place, but deformities were noted to be present in the bilateral upper extremities and the left lower extremity, and we're able to obtain signals to the left lower extremity. So there's obviously some type of deficit there with palpable pulses elsewhere. The resuscitation that he received actually quite quickly, because the rapid transfuser and the Cortez allowed us to administer these products pretty quickly, improved the patient's vital signs to 105 with his heart rate and 115 systolic blood pressure at this point. So now we've completed our primary, our adjuncts, and our secondary survey.
Where was the introducer, Bobby? What position? Where'd you put it?
We put it into the left subclavian.
Okay.
How often do you use that? I mean, the left subclavian. I thought that in the last 10 years in shock trauma, we're not using very much that. I guess we have big IVs in the arms, 14 gauge, and we're able to do as much as take to put it left subclavian. I'm glad you didn't say you put a revolt. I guess that's Colombia meeting.
No, that's only if shock trauma is presenting.
Okay.
Thank you, Dr. Rodriguez. Dr. Lieberman, can you hear me? Is Dr. Lieberman with us? Dr. Cortez?
Yeah.
Do you have
Yeah, can you hear me?
Yes, I can. Do you have any comment?
Perfect. Yeah, just really briefly. You know, the question about the binder and the x-ray before or after, and yes, you can usually tell an open pelvic book, fracture on physical exam. But the difference between putting on the binder during your physical exam and waiting for the x-ray, especially the way things are set up at Jackson South, you're talking about 3 minutes, maybe 5 minutes on a bad day, because x-rays are literally 6 inches away from the bed.
Dr. Lieberman, we can't hear you.
So the
Dr. Lieberman?
Yeah, your connection is no good, Dr. Lieberman.
Yeah.
Either you're in a bunker or you're somewhere with a bad signal.
No, I'm at my house. I don't know why.
Okay.
Yeah.
That's a little better now.
You.
Is it better now?
Yeah.
Yes,
Yeah.
better. Thank you.
Yeah. So basically, the binder went on, in a timely fashion. Had we not waited for the X-ray, maybe we're talking 3 minutes earlier for the binder. So it wasn't like he went all around the hospital and then finally got the X-ray and got a binder. But I agree. Once you know there's an open book pelvic fracture, you should think about a binder. Like I said, the X-ray was obtained in a very expeditious fashion and put on right away. The other question was the needle decompression. EMS in Miami likes to do it pretty often. I'd say on the best of days, it's 50-50 whether it actually does any good, and 50-50 whether it does more harm than good. Half the time it's not in the thoracic cavity. And recently they started to do, instead of mid-clavicular second intercostal, they started doing mid to anterior axillary line. It should have been fourth intercostal. I had one patient like that. And of course, that was a patient that had a diaphragmatic rupture and had the liver in the chest and now had the decompressive needle in the liver. So yeah, it's I agree. It should be sort of really done as a last minute, sats are dropping, patients either developing a tension pneumo, things like that. Because like I said, most of the time it's not in position. And if you have a diaphragmatic rupture, like we had in another case, the needle went right into the liver.
Thank you, Dr. Lieberman. Dr. Cassin, would you do something different?
And no, not really. The timing, like Dr. Lieberman mentioned, is minuscule in the grand scheme of things, 1 to 2 minutes. But as long as you have that in the back of your mind, I think you're doing okay. And regarding the needle decompression, I don't do any more intercostal needle decompression. I've resorted to using the mid-axillary line, and I use a long angiocath, and I put the needle in and pull the metal needle out, leave the plastic tube in there. Even if it is sitting in the liver, it is not a big deal. So those are all esoteric discussions. But as long as you think of this in a critical situation, I think you're doing your patient some good.
Yes, for the,
Now,
I'm sorry, go ahead.
regarding what to do next with this patient is where we are going to be looking forward to seeing what was done, and I'm looking forward to hearing from the presenter what he's going to do. Thank you.
Dr. Cortez, just for the benefit of the residents maybe listening to them here, what kind of chest tube you put, what number? Because I will always teach the residents, the fellows in shock trauma, that chest tubes are there for drainage and not for ornament. And to put in trauma at 22, 28 doesn't help. We used to put big mamas 40s. I don't know if that exists, to drainage. These days, minimalistic surgeons, they're trying to put everything minimal, do minimal thing and heal minimally the patient. So what chest tube you put?
Yes, sir. I think it was the 36 French was what's there in the recess bay.
All right.
It's a sizable chest tube. So thank you all again for your points. Appreciate all of them. So again, after his resuscitation here, our vital signs had improved significantly, such that we were able to expedite this patient to scan for a pan scan head to toe, which we'll go through now. So CT brain will demonstrate a couple areas of concern. You'll see a left intraparenchymal bleed that's small here, and then a left frontal intraparenchymal hemorrhage here with no shift, and again with a patient who arrived with mentation and was talking to us. Moving further, here's a CT chest that was performed. We can see our left chest tube in place. Nothing in the contralateral chest, no significant contusion, so to speak of. The chest tube in position there with no undrained component of a hemothorax. Now the abdomen here, we'll see blood laying around the liver here. No free air present on scan. You can see a right pericolonic hematoma here with the retroperitoneal component of the hematoma as well on the right side. This was carried through as a CTA given his left lower extremity vascular discrepancy. There were signals rather than pulses. And I'll turn your attention to the left lower extremity. We can see the SFA and profunda delineate here around the areas of a left-sided femur fracture. There's the femur fracture, at which point the profunda goes out. His left leg is supplied by his SFA, which carries on to 3-vessel runoff distally on both sides, on the left side. Now on the delayed phase, and I'll turn your attention here to the delayed phase in the vena cava here. As we carry this down, and again, the retroperitoneal hemorrhage was noted on the initial scan on the right side. If we carry this vein down, we can see the bifurcation, the right common iliac vein, and then some bleeding here. And then right around this area, it was read as a large pseudoaneurysm of the common iliac vein on the right with active contrast extravasation. And to round out, just to kind of show other kind of trauma, the injuries he had, gross deformities, mid-humerus, left radius ulna, and then the left femur fracture here. So in terms of, we get the patient back to the resus bay, his vital signs remain stable. He's received those resuscitation products we previously mentioned. And then going over the top-down injuries that are noted at this point, left frontal intraparenchymal bleed, left intraparenchymal hemorrhage at the vertex with no shift. He's got blood in the abdomen. He's got a hematoma around his right colon. And then on the delayed images, we can see a common iliac vein injury with extravasation, broken left femur, which looks like it involves the profunda artery on the left with 3-vessel runoff distally, pubic diastasis, bilateral superior inferior pubic rami fractures, and then the orthopedic injuries listed below. So now we have pretty much a top-down view of what injuries we are faced with in a patient who's now back in our resus bay with what to do next.
Thank you, Dr. Cortez. Dr. Namayas, do you have any comment, please?
No, I don't really have any comment. We've got a bunch of blood in the abdomen. We got this hematoma around the colon. We had shock. We have the pelvic bound up. He's gonna end up with a laparotomy.
Okay. Thank you, Dr. Namayas. Dr. Antrak, would you do something?
Yeah, so yes, I don't recall, was he wearing a helmet? Probably was wearing a helmet.
Yes, he was. Yes, sir.
Yes, okay, that's why the brain injuries are small the way they are. So that was good for him. So in this case, I would splint all the extremities. The profunda on the left shouldn't be an issue. I would run it by the vascular surgeons, but I think just a traction splint on the leg should be adequate. There should be enough collateral circulation to the left thigh. The pulses should be normal in both feet. 3-vessel runoff. There's really no issue distally. About the abdomen, so it looks like there's no splenic rupture, no liver rupture. The kidneys are normal. There may be some bleeding around to the right colon, and he's got that internal iliac venous bleeding in the pelvis, and that bleeding should stop with the reduction of the pelvis. And so then the issue is, I think it's reasonable to go to laparotomy, and when you get there, take care of the bleeding in the abdomen. But it seems like the amount of blood there is rather limited. The other option, since you're on a roll, is maybe go to angio or to a hybrid room if you have one, so you can start with angio and then do a laparotomy if you need to, and see about evaluating the right colic artery, since that's where the blood seems to be coming from. Maybe there's a bleeder there that can simply be thrombosed, and rather than doing a laparotomy and ligating it. And then the other issue is whether the angiographer can thrombose the right iliac vein on both sides to get control of that bleeding. And then after that, simply either an X-fix or leave the binder on, and eventually see if the orthopedists need to do an O or IF of the pubic symphysis and then the 2 ischial fractures. But seems like it's rather lucky. So, but you have the options, either laparotomy or do what Dr. Fraga would do, is pursue maybe angiography.
Thank you, Dr. Antrack. Dr. Rodriguez, any comment?
Yeah, this is for the residents. I don't think it's anyone. Everybody's working, doing the work. And there was 33 people that probably are not residents. But just for the chest, where you pass very quickly, you know, I always worry about the aorta. Since we at one point we were the experts in aorta, not anymore. Everybody put the stents and all that kind of stuff. But anyway, well, we learned from Mervis the super radiology or trauma radiology. There are two signs for the aorta that you look. You look periaortic hematoma and lack of contour of the aorta. The periaortic hematoma is, in these days, questionable, but definitely the aorta contour is abnormal. It's a ruptured aorta and they prove otherwise. The second, commentary about the injuries in the belly, definitely hematoma in the colon and the patient have been hypotensive at one point. It's worth, I think, to do laparotomy and take a look. Now, this patient, what is the role? I asked the panel, will be here pre-peritoneal packing before surgery, you know? It's something that, you know, below the umbilicus, 6 centimeters, a pack 6 in one side, retro, because he has sacral fracture, I hear. So you do pre-sacral hematoma, 3 packings then, 3 packings on the other side. You know, 80% of the bleeding in the belly and the belly and pelvic fracture is not arterial, it's venous, so, which is this case, has a venous injury. So that'll be my commentary.
Thank you, Dr. Rodriguez. Dr. Cassin, any comment?
Well, the patient has evidence of intra-abdominal bleeding with blood around the liver. And then he also has some evidence of bleeding in the pelvis. And then he has a contused looking colon. If you add all these up, I don't believe there is any room for conservative or non-operative management. I think Professor Nemaya is correct. This patient belongs in the operating room. That's where he should be immediately. And that's where I would take him and do a thorough exploration. Now, what would I do there? I would open him up, open the belly, and have a look inside the peritoneal cavity to see where the bleeding is coming from and stop it. And then look at the venous part of the injury that near the infravena cava to see if that needs to be dealt with or not. Then perhaps, and I would go with Dr. Rodriguez's idea of packing the pelvis and then getting out of Dodge City into the ICU. Thank you.
Thank you, Dr. Cassin. Dr. Lieberman, any comment?
Yes. So I agree with pretty much what everyone is saying. And in my mind, when this patient came in, before we took him to the CAT scanner, I knew he was going to the operating room. There was no question about it. He was going to the operating room. We did the CAT scan because, for 2 reasons, at least in my mind. One, we were able to get his vitals normal. I wouldn't say he was stable, but we got them normal. And this guy came in so broken. I mean, his limbs were pointing in the wrong directions. They were bent in ways that they should never be bent. And given that, and the mechanism was that he was hit by either a truck or a pickup truck. The report was he did have a helmet, but I never saw a helmet with him. So my concern was he would have a devastating brain injury. I would take him to the operating room, spend hours there just to have a brain dead patient at the end of the case. So that was one of my reasons why I wanted to scan him. And also, given all his injuries, I knew there was probably more to the picture than what I was seeing. So any pre-operative information I could obtain in a safe fashion, I wanted to have. And that's sort of why we scanned him. And then once we got all that information, we kind of were able to get all our ducks in a row. And as Bobby will explain, tell you what happened, you'll see, I think that getting that CAT scan instead of going directly to the operating room definitely helped this patient. And there was no, like I said, there was no question or doubt in my mind. This guy was going for surgery, right away. It wasn't even, once he was unstable, when he came in with those, tachypnic, tachycardic, hypotensive, positive fast. I mean, in my mind is already made up.
Thank you, Dr. Lieberman. Dr. Collet, can you hear me?
Yes, I agree to all comments. But in this case, I agree that these patients need to go to AOR and make a laparotomy. No conservative maneuver, and you have a blending from surrounds that for a vein. It's not in angio can be done. So the great problem is maintain the binding during the surgery and try to see if it's necessary to make a pelvic packing as a surgery. But I think is a great problem is the vena femoral iliac vein blending. So it's very important to control this blending because it's very big blush. So I think this is a great problem for this patient. And try to find all the blends also in abdomen. Then I think after them, if it's necessary, I go to angio and see if there is another problem. But at this moment, the patient need to go to AR.
Thank you, Dr. Collet. Dr. Cortez, your turn,
Yeah.
please.
Yes,
Can
thank you.
I make another comment, Dr. Cortez? I'm sorry to interrupt you all the time.
Yes, sir. Yes, yes, sir.
But I don't know. I think we all agree the patient needs laparotomy, I guess. But I wouldn't go directly to see the pelvis. You know, you have to be a sequence unless the blood is coming in my face and the pelvis, I address that. But you have to look the whole abdomen. It's understandable. It's for the resident, you know. You have to have a system or evaluation because you don't go directly to the pelvis and the bleeding. I don't care what the CAT scan show and above the liver, spleen. Number one. Number two, I think the role of the preperitoneal packing is not after or during the laparotomy because actually the preperitoneal packing it shouldn't be connected to the laparotomy, otherwise lose the pressure, you know, the compression effort. So this is the two comments. And I think we all agree that this patient is really broken, and we have to be assuming that there's more than perhaps what we're describing now.
Thank you, Dr. Rodriguez. Dr. Cortez.
Yes, thank you all. Again, thanks very much. So we'll go into the next steps here. So as everybody agreed, the patient was expedited to the operating room where we performed a laparotomy. Hemoperitoneum was noted upon entering the abdomen, which was packed and then systematically viewed in all four quadrants. We were able to run the bowel, and we saw two areas of mesenteric injuries, bucket handle injuries that were about 10 centimeters in length. The first one we noted was about the mid-jejunum, and then there was a second bucket handle injury that was noted at the TI, extending about to the level of the cecum. The right upper quadrant was fine, no bleeding. The left upper quadrant was fine, no bleeding. Then as we got down to the pelvis and then the right retroperitoneum, we noticed an expanding hematoma around the right colon and within the deep pelvis in the type 3 or zone 3, I should say, zone 3 retroperitoneal space. So I'll keep moving just to kind of talk about and get through the rest of the case. What we performed at this point was a small bowel resection of both areas of mesenteric injuries at the mid-jejunum and the terminal ileum. Now, we had note of a injury to the common iliac vein on preoperative imaging. We did make a phone, this did not delay the case, I should say, but we did make a phone call to vascular where one of the attendings thankfully was gracious and came in with us. We had already gotten the case started by the time he entered the room, and we're able to systematically approach the venous injury in the following fashion. So we're looking at the right retroperitoneum. There was an expanding hematoma there with thought of being the distal control maneuver here would be a cut down and clamping of the common femoral vein on the right, which we did. So we made an incision here in the right groin longitudinally, got down to the common femoral, placed the clamp on. And then we noted bleeding coming from below and around the inguinal ligament. And as we traced the venous anatomy upward, we actually saw a longitudinal laceration that was made probably from his adjacent pubic rami or pelvic fractures that was about 5 centimeters with active bleeding. So we primarily repaired this with a running 5-O-proline, which allowed us to turn our attention back into the abdomen, where we performed a right medial visceral rotation. And then we mobilized the right common iliac artery medially, which allowed us to see the entirety of the external iliac vein and the common iliac vein on the right. So we had one injury down here near the inguinal ligament that we had repaired. We placed a clamp just up here past the bifurcation for proximal and distal control. And we actually found two more pretty significant injuries along the length of the iliac vein. There was one that looked like it was an avulsion injury right where the internal iliac vein takes off with the clot that started, that was an injury there, which we primarily repaired. And then as we marched even farther upstream, the pseudoaneurysm that was evident on the scan was probably around this area, and it was posterior. So we actually had to mobilize the common iliac vein to see the posterior surface of it, at which point we repaired that area. The patient was placed in, obviously left in discontinuity in a damage control fashion, and a temporary abdominal closure was placed at this time. Now, orthopedics had pretty much been right at the bedside with us for immediate damage control orthopedic repairs, to include an X-fix of the pelvis, traction pin and in the left tibia, and traction of the left femur fracture, and then quick INDs and splinting of his extremity fractures right after he was done at that point. So that completed our initial operative management for us. So we can kind of pause here.
Thank you, Dr. Cortez. Dr. Lieberman, do you have any comment?
Yeah, as Bobby said, once we had the CT images and the plain films and everything, we made 2 phone calls, one to ortho to sort of tell them what was happening, that we're going to the operating room, one to vascular. And this, I mean, everyone works at different institutes and things of that nature, but this just emphasizes what, what an asset it is to work at a place where you have amazing colleagues and people that have expertise that, may be better than your own and are there to help you. Because I made one phone call to the vascular attending. He wasn't even on call for this hospital, but I told him what the injury was. He's like, don't worry, I'll be there. Immediately, Bobby and I started the case, and it was pure, luck that the timing was like perfect. Just as we were finishing the abdominal case and doing the, the resections and finishing everything in the abdomen, the vascular surgeon walked in and he started to get distal control. And this injury was, I mean, for all of us who've had common iliac injuries, internal, external iliac injuries, they are very, very difficult injuries to manage. And this, injury of the, external iliac vein, this long linear laceration that was at least probably 5 or 6 centimeters. It probably went from, up to almost to the confluence. It stopped right where the internal iliac vein, took off. So right at the bifurcation. And it was a posterior lateral long linear laceration that, luckily, like I said, one of the vascular surgeons was there and was really able to repair that injury. And then the whole vein just going up and down was destroyed. And because of the pelvic fracture, the inguinal ligament was basically just obliterated. And because he had bilateral superior and inferior pubic rami fractures, that little segment of bone, that like little butterfly pattern, was kind of just free floating everywhere. I mean, that was moving around. Like we could literally have just taken that entire complex of bone out of the pelvis. So his pelvic injuries and his vascular injuries were really, really devastating. And I'll say it a million times that those pelvic venous injuries are worse than the arterial ones.
Thank you, Dr. Lima. Dr. Rodriguez, do you have any
Yeah,
comment?
I have a few comments. Number one, I don't know, it's a blessing to have orthopedics very available, or the opposite, Orthopedics depends, orthopedics not necessarily help early because they are, in general, I'm sorry, there's orthopedic listening, they are not very soft with the wounds, and they can disrupt you more than help you, okay? To put the fixators and that's it, but then they actually fixation of the pubic symphysis is not a priority for them. It's not an emergency that they do late. Okay. Number two, if this patient was bleeding, then you had to open the peritoneum and call the vascular surgeon to repair the vein. How many people in the audience has done this repair? The repair of the vein, the iliac, is very difficult. Sometimes you have to cut the artery and move it to the other side to repair the vein. So yeah, it's nice. This is Hollywood, you repair a Hollywood way all the vein. I think very few trauma surgeons will be able to do that. I probably have done one vein repair, but most of the time I ended ligating because it is more dangerous. The position, the location of the vein is very awkward to be able to be repaired. So if this patient was bleeding, hematoma was expanding because vein probably can clot it, you know? Yeah, obviously this seems like a very serious vein injury, but how was the situation? It was the patient hematoma expanding to the roof or something like that? You're obligated to do all this at Hollywood surgery, really. First, I'm not going to have a vascular surgeon. I'll have to repair even in shock trauma. We rarely never called it vascular surgeon, but tell me, what was the situation with the hematoma? You couldn't leave alone? It was.
I think over the course, as we said, we were able to visualize it as we started the resections, and then it was certainly significantly larger where we felt it was necessary to address it.
Okay, was bigger than you thought.
Yes, it was bigger. Yeah, certainly expanding.
Okay.
Aurelio,
Yeah.
you mentioned Hollywood surgery, and I think one of the biggest Hollywood surgery is that picture we've all seen that you mentioned where you cut the iliac artery to get to the iliac vein. I've never done it. I've never known anyone who's done it. I've seen the drawings of it. Has anyone here done it or know of a patient that had that done? And is it just crazy beyond all belief to cut the iliac artery to get to the vein?
I never have done one, but that I mentioned because it's a book, right? Beautiful picture. But
Yeah.
I'm telling you, in this, because it's very hard to get into the vein. That's why I keep repeating that. The vascular surgeons have the technique to do it, but not everybody has the privilege that you have to have this vascular surgeon here to come and do it.
Howie, they didn't cut the artery to get to the vein.
Yeah, so let me just say a few things. So I've had a couple of these injuries. I guess I don't know if I'm lucky or unlucky. And usually you just, either, like you said, end up ligating it, or if you get a little lucky, you could actually find something to sew. I have to say, in this case, we had mobilized the artery so well and retracted it out of the way. There is no reason ever to cut that artery. I mean, there was just no reason. It was never in our way. We had amazing, beautiful exposure. And because we did it very methodically, from the actual venous injuries, we had like maybe 20 cc's of blood loss. It was so well controlled proximally and distally. We had everything ready, everything to go. It was really, like I said, it was just very lucky that, when the vascular surgeon was there, I was there, Bobby was there. This whole thing was set up perfectly. It went really, 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 really well. One of the least bloody venous repairs I've ever seen. And there's no reason to transect that iliac artery. I mean, there's just no reason. I mean, we mobilized it, retracted it.
I kind of want to clarify. I'm not proposing to cut the iliac artery. I'm mentioning.
Yeah.
Because,
I know it. Yeah, I know it's described and it's talked about, and I just don't see a reason for ever doing it.
Now, but there is a reason, and I have divided the internal iliac to better mobilize the common and external together. So I've done that. But these are terrible injuries. They're hard to get enough hands, enough light, enough exposure in that place to then work. So they're awful.
Yeah, I wish I had the pictures because the injuries were just really impressive. External iliac, common iliac. It was just, they were, sizable injuries that, needed to definitely be addressed and repaired, or at the very least, like.
I have a question for you, doctor. What would you do if the patient is in shock? Obviously this patient was totally stable. This was an elective procedure, basically, repair of the vein. What would you do? Ligate and forget about it? Sean, what would you do? Dr. Cortez?
I think we had as I said, the stability of the patient at that point, which allowed us to proceed with the repair. But in the opposite case, as you mentioned, probably just ligate that vein. But we saw the injury actually carried quite downstream. It was just past the common iliac bifurcation. So to ligate in terms of controlling the bleeding really would have had to extend all the way up to right where the right common iliac took off, would have been very high. So I think even addressing it and mobilizing the vein, getting the artery out of the way allowed us to see a very impressive injury, as Dr. Lieberman mentioned, that extended very, very high, which allowed us to kind of take that. But I see what you're saying. Extremis in that case, luckily we had hemorrhage control, but I would ligate if we had no other choice.
Got a call. He said the trauma surgeon is getting the specialist, and so if you need to talk to, that's just Joel's number. But he said the trauma surgeon.
Okay, he
is
just needs
actually-
to, okay, that's fine. Thank you. Great. Thanks a lot, boss.
Dr. Kassim, do you have any comment?
Well, you know, there is a saying, sometimes it is lucky, sometimes it is good to be lucky than good. And in this case, I think it is the goodness of the surgeon, people like Dr. Lieberman, who really is a good surgeon from what I am observing, just listening to him. He is approaching this methodically. He dissects everything out and puts everything out of his way, doesn't have to sacrifice the iliac artery, which is crossing the iliac vein. And by the way, it is Dr. Dimitriades who recommends that extensively for doing that. I've never done it, but it's in the books anyhow. The other alternative you have to an injury like this, if you're not a vascular surgeon and if you do not have colleagues like Dr. Lieberman has at the Ryder Center, and sometimes, you know, it is worth thinking about putting in a shunt. You know, you already have a tear in the vessel there, and put a shunt in there and leg it to the top and leave the shunt in there. And if it's not bleeding anymore, and you know, you're at least out of the woods, and then you can come back and deal with it at a later date. And of course, the third thing is going to be ligation. Ligation has its own sequelae postoperatively, but it is a life-saving measure and it is deployed in certain instances. Thank you.
Thank you, Dr. Kassim. Dr. Antrak, any comments?
Yes, so I think, beautifully handled case. And I think the success is because of the approach of Dr. Cortez and Dr. Lieberman to get the experts, in this case, the vascular surgeon. So if I understand correctly, the laceration in the external iliac was repaired through the groin incision, and then the injury to the common iliac and internal iliac through the laparotomy. Is that right?
Yes, sir, that's correct.
Yes, and then that would have been very difficult with a large hematoma, and so you had a good expert who can concentrate on that, and it worked out well. Now the obvious question is, with that extensive injury, longitudinal injury in both veins, I'm sure you checked for patency postoperatively. Did the vein remain patent, or did it thrombose? And that would be the issue, because what's the status, and the status of the leg? Is it swollen? But I'd be interested to see, because if it thrombosed anyway, then that's the if you needed to ligate it, that's certainly you'd be in the same position in either case. But it was handled well, and a very nice case. And I think also the bucket handle injury, you can't see those unless you do a laparotomy. So that's the one argument in favor of even if you that to take a look, and you've avoided a complication later by doing the laparotomy immediately. So that was very good judgment.
Thank you, Dr. Antrak. Dr. Collet, do you have any comments?
No comments. I think it's very difficult to injure the vein to treat. I know that sometimes it's possible to make a section of the iliac artery and then suture the vein and reconstruction of the iliac artery. I believe it's a difficult place to do, but I have one fellow of mine that do this and considers saving the patient. So I think it's not impossible to do this, but sometimes it's very difficult to do. One thing is maybe possible in this situation that you have an injury of iliac vein with a very big hematoma. Maybe in these situations, put a catheter through the femoral vein and with a balloon that you can occlude help to occlude the injuries of the pseudoaneurysm in this situation, and maybe more safety sometimes to do the repair of the vein, or gain time to control the hemorrhage. but usually I go to try it directly and try to suture the vein. The vein can be sutured or ligated or tied. The tied may be problem with the leg, with deep profusion venous thrombosis, and it's very difficult to treat sometimes the leg. But if you, it's the best you can try to repair the vein, but sometimes it's not possible. I agree with all the others' comments, and it's a very great case.
Thank you, Dr. Collet. Dr. Rodriguez?
Yeah, I just want to throw something here that hasn't been mentioned. Is understandable. Again, I think these conferences are not for us to show who knows more than we or the other. It's for the resident. I hope there is some resident, but I know and the residents are working as for the OR for cleaning some page, but that's okay. But fasciotomy, you know, the role of fasciotomy here, because these people in certain places will exaggerate. I was told by L.D. Bridgeport, you know, the president of the college, who said he trained in Cook County, and they did prophylactic fasciotomy. Any vascular and the leg trauma, they start with fasciotomy, 5 minutes, to do fasciotomy, and then they approach the vessel, the artery, or the vein. In this case, it can be done with you. More likely, this is going to clot. I guarantee to you, this vein is going to narrow and it will probably not be functional. If it's functional, it's not going to be good enough. So maybe a prophylactic fasciotomy. Did you do any fasciotomy in this case, or was contemplated, or what?
No, sir, we didn't. We felt like he had adequate inflow and then good vascular exam. So no, we did not. And to answer Dr. Ultra, your question about the ultrasound, we did a duplex quite recently. It showed no DVT and patency of our repairs up through the iliacs and et cetera.
Sorry, I just want to say something that this is a long case, and literally this is the easy stuff we just spoke about. Bobby still has a lot to talk about. I know we only have a minute or two left.
I may if everybody agrees, I'd be happy to come back in the future, and we can give the rest of the case kind of the attention it deserves, because I think this was the initial approach, and then Dr. Lieberman and I ended up having both acute postoperative, but more prolonged postoperative complex issues that we brought up with open abdomen and closure of the open abdomen and some literature. And so, you know, I think we can go through that quickly, or I can come back.
13 minutes, Dr. Cortez.
How long does he have?
13 minutes.
13, we go to 8, we go to
Yes.
9, 10?
Yes, no problem.
Okay, because I have to leave, so however you want to do it, but it's a great case.
I think we'll.
We'll just do a second case, a second session.
Yeah, I think if you are all okay with that, I'd be happy, absolutely happy to come back. We'll talk about, we'll leave this as kind of the leaving off point, and then I can pick up right after this, and we can go from there.
We actually don't have a case for next week, Monday, so maybe we can continue the discussion then.
Sure, I'd be happy. Yeah, that'd be perfect. Actually, I'd be happy to do it.
Perfect.
Okay, so then I think then we can end the discussion here today.